Hey there, and welcome back to the Rapid Response Earn podcast. Today's episode's a little bit different. I usually share a real-life story and then use that story of the emergency case that I responded to then break down the pathophysiology and the pharmacology and all that nerdy stuff that I love. But today's episode's different, so I wanted to respond to a question, actually two questions that came in the same week, from nurses who want to learn how to be a better preceptor. A lot of you are getting assigned new grads or even nurses that are new to your unit but not new to nursing. And no one's actually ever trained us how to be a preceptor. Like in nursing school, you learn how to be a nurse, but no one's like, and here's how you teach someone else how to be a nurse. That's a whole other skill set. And I actually did a whole Friday meetup on Rapid Response Academy about being a preceptor. And so I'm not going to share the whole thing with you. It's an hour and 7 minutes long because we actually went over. There are so many good questions from the Rapid Response Academy members. But I do hope to share with you some of my top tips and tricks that I've learned over the years, being a preceptor myself, being a professor, being the ER nurse educator. I got to watch a lot of new grads be successful, a lot of preceptors really hone their skill, and I've also got to see a lot of people maybe not precept so well. So I hope to share with you all of the wisdom, both the good and the bad from my years. So sit back, maybe grab a pen and paper if you want to take notes. I hope to share with you not just like the practical skills for being a preceptor, but also my heart behind what our role is as the preceptor. Hope you enjoy it. Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. So I started out our Friday meetup just describing my experience with my first preceptor as a new grad. I actually worked in the ER as a nurse tech or a CNA all through nursing school. And so I had the opportunity to pick who my preceptor was because I already knew all the staff. And instead of picking one of the primary preceptors, I picked who I thought was the smartest nurse on the unit. Was he nice? No. Was he a skilled educator? No. But he really knew his stuff, and I had saw him perform optimally in an emergency situation. So that's how I wanted to precept me, was who I thought was the best nurse on the unit. Turns out you can be a really great nurse and not be a good preceptor. He didn't take time to teach me much of anything. I kind of just followed him around. When he finally gave the opportunity to do something independently, I actually made a meta error. I gave the wrong antibiotic to the patient because back then we didn't have scanning of meds. I went to the Pyxis and typed in CEF, and I got cefepime instead of ceftriaxone. Administered to the patient. I caught my own med error, and holding back tears, I went in to tell him the error that I had made. And rather than taking that as a teaching opportunity or walking me through how to prevent it in the future, he was just well, that's it. I guess I can't trust you. Can't get meds on your own anymore. I have to watch everything you do. Yeah, that was a really, really tough preceptor experience for multiple reasons. So contrast that with, I went from orienting on day shift with a very experienced nurse that wasn't really the best preceptor. And then I finished my orientation, went to night shift on my own. And they said, you don't have a preceptor on nights, but there's a nurse we're going to assign to as your mentor. Her name is Bonnie. And Bonnie was awesome. Bonnie had been a nurse for far less years than my preceptor had been, but she instilled so much confidence in me. She was such a good teacher. I actually still get to work alongside her in the hospital. She's amazing. And every time I see her, I'm just filled with so much gratitude for all that she gave to me as a new grad. So I'm going to drop you right into our Friday meetup from Rapid Response Academy. to hear about Bonnie.
So that was my first experience. No mentoring, no guidance, just like trying to keep up with this guy who was a very good nurse, just not a good preceptor. So I go to nights. They're like, well, we're going to put you on all of Bonnie's shifts. You're going to have your own team. You're functioning independently. But if you need something, Bonnie will be there for you. She'll be like your mentor, your go-to person on nights if you have questions, because, you just graduate 1 month ago. Okay, so I get to nights. Whole different story with Bonnie. Bonnie loved teaching. She was so approachable. She was so compassionate. If I had a question, she'd be like, great question. That was her response. Oh, great question. Yeah. And she explained it all to me. And after something, I could get help with something. She's like, absolutely. And I still say that because I've learned from her. Someone needs something. Absolutely is my answer.
So the summary here, the takeaway from my preceptor experience is you don't have to be the most intelligent, the most experienced nurse to be a great preceptor. In fact, you can be an awesome preceptor just a year at a school. If you understand what your role is as a preceptor, it's just to help someone be independent and to function safely without you there. So we're going to dive right into talking about how to promote self-efficacy in the people that you are teaching.
Self-efficacy is like when the learner believes that they can pull off the task. So there's efficacy, you can do it. Like this thing works, right? You work. But self-efficacy is realizing that, having the confidence that you actually can do it. All right. Establishing expectations from the beginning, pay the confidence bank before withdrawing, master the art of the sandwich method, use Socratic questioning, set goals, debrief every shift, and build them up in front of their peers. Okay, let's talk about establishing expectations. So as soon as you get assigned this new hire, maybe this nursing student, whoever you're going to be precepting, decide inside yourself what you want them to know about you, about your teaching style, about your expectations, how you do things, so that they're not surprised whenever you have a certain standard you're holding them to and they've never even realized it before. So I would even start with hey, just so you know, I'm here to guide you, to support you, to mentor you, but my goal is to help you do this on your own. So I will be here for you, but I don't want to carry you the whole way. I want to slowly give you more and more responsibility so that you can do this without me ever even being here. I always say things like, I move fast, but feel free to interrupt me at any point and ask questions. I will never judge you for asking questions. Always know that I am a safe person to ask questions to, whatever question. I'm fully aware the nursing school did not prepare you for everything you have to know in this role. I hope to fill in all of those educational gaps. And then I tell them, I will be asking you a lot of questions that I don't actually expect you to know all the answers to, but this is how we're going to develop your critical thinking skills. So just a little statistical backstory. They studied and they gave people a lot of information. Someone is lecturing, just telling them all the information they have to know. Of that content that someone's just telling to you, you will retain about 30% of that. 30% as nothing. However, they found that when educators asked questions to the audience that they had not even taught yet, and the audience was like, I don't know the answer to that. And then they proceeded to explain the answer or to walk them through finding the answer. They retained about 90% of that content. So there's something about our brains where when we're like, hold on, I don't know the answer. Well, I need to know and retain this answer. So I'll ask people's questions and I'm like, I know they don't know this. They haven't been a critical care nurse. They haven't been an ER nurse. But I'll ask them, what do you think is the rationale for doing the blah, 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 blah? And then they'll be like, And even if they have no idea and they give the most off-the-wall answer, I always say, you're on the right track there. Let me explain it further. And then their mind, something about it, they're like, I have to have and retain this. So when you do give the right answer, they will actually remember it. So I just don't know ahead of time. I'll be asking you questions too, not just you asking me questions. But the goal is to help you critically think and to help you actually retain what we're talking about. I'll ask them, how do you like to learn? Do I need to be drawing stuff for you? Do you want me to put your hands on it and talk you through it? Or should I do it first and you watch? How can you learn the best? And I will try to match whatever teaching style I give to match your learning style. What are you most excited to learn? Let's start there. What scares you the most? Let's get that out of the way. So just from the beginning, establishing expectations is so important.
In this next section, I go through some of the strategies or mindsets that I have as a preceptor that I found to be very advantageous, help me be successful, help the new grad be successful. And the first one I call pay the confidence bank.
All right. I love this concept. not just in precepting, but also like in parenting and relationships with your spouse. I call it pay the confidence bank when it comes to precepting. When it comes to relationships, I call it pay the relationship bank. Okay. So think of it this way. Every person has a bank, and you either are making deposits or withdrawals from that bank. The deposits are positive affirmations. Here's where you're doing good. Building that person's confidence up. Withdrawals are needed, but that's when you're like giving critique, giving like very clear feedback of what could be improved upon. The thing is that you do need both when you're precepting someone and when you're in relationships with someone, but you want to make sure that you don't have more withdrawals than you have deposits. So sometimes I'll just be giving deposits like crazy, like so many deposits, constant. So when I have to sneak in there and give some sort of negative feedback or some guiding feedback or a firm hand, the bank is already full of so many deposits, they can handle a withdrawal. But if all you're doing as a preceptor is withdraw, you did this wrong, change this, do this different, I don't like this, they will be running on empty, and that's how you like squash their souls, and they don't feel like they can learn from you. So you want a learning environment has a full bank with some withdrawals. Withdrawals are necessary, but not like crazy. To be more specific, I've had a lot of preceptors, and let's say I tell them all the time they're doing great. I told them they're doing great. Okay. I mean, that's like the hospital saying like, you're our heroes, healthcare heroes. You're like, cool. Like, that's really vague. Thank you for thinking I'm a hero. But like, specifically, what did I do? That's why Daisy Awards are so awesome, because it's specific. Like, here's the specific thing you did that was awesome for patients. That really feels like a compliment. That really feels like encouragement. Like you're appreciated and recognized for your value. Not just like, you're doing great. So when you're giving deposits, you're doing very specific ones. So here's some examples. You responded perfectly to that family's concern. You are very organized in how you set up to pass medications. Your note was so clear and concise. Great job. I see you paying close attention to sterility. Excellent. So I'm saying specifically what I'm noticing that I think is a good behavior or something that they should be replicating, even if it's small, right? Like, very clear note, you're really doing good on the sterility. But all those things build their confidence, build their self-efficacy. So when I have to make withdrawals, because I will, they can handle them. So withdrawals on the flip side of these deposits would be, can I give you some feedback about how you responded to that family? And then kind of talk about maybe what they could have done differently. Can I show you some ways that have helped keep me organized when I'm passing medications? Your note is off to a good start, but here are a couple key pieces that are missing. Let's pause and talk about sterile procedure before moving on, right? All those things are necessary. I need to give that feedback as a preceptor, but I better have had some deposits in the bank before I start making all the withdrawals. And I'm sure you're thinking, listen, some of these new grads, all I can do is withdrawals. Like, they are terrible. You have to find a way to get deposits in there. There are things that they are doing that are good, and you are going to name and point out every single one of them so that you have the space to give that withdrawal.
This next section, you've probably heard it before. I call it the art of the sandwich method because it really is an art. It can sound really canned and cheesy if not done well. So let me just share with you my spin on it.
All right. The art of the sandwich method. Who has heard of the sandwich method before? I think it's kind of a common thing. I see some hands. Yeah. All right. I've also heard it called a compliment sandwich, whatever you want to call it. It's so good. And I'll see like my boss doing it to me. And I'm like, don't sandwich method me. I see what you're doing. But it's still so much better received whenever they give me the feedback with the bun on the top and the bun on the bottom. So the bun on the top is a compliment, an encouragement, positive feedback. It's like the fluffy bun, happy stuff, right? And the meat in the middle is what they really need to hear. The constructive feedback, opportunity for improvement, some sort of correction. But after you give that meat, you always have to end it with a bun at the bottom. And the bun at the bottom is another compliment, some sort of encouragement, positive feedback. And I always end with like, I know you have what it takes to do this thing, to overcome this obstacle, to meet this challenge, to whatever the thing is. Let them give confidence that I know you can fix this thing, that you can do it better, right? A common one with my boss, I actually might have noticed I'm very passionate. And so sometimes I'll send emails within the hospital system that maybe we're a little too passionate. We're like, Sarah, I love that you are so dedicated to improving patient outcomes. I mean, you are the person we need for this job to make changes in healthcare. Your one email that you sent to the CNO where you said blah, 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 blah. I feel like maybe you could have chosen different words that weren't so emotionally charged. So I like, but then he ends it with, but I'm so glad that you're addressing these points. Like he always starts with compliment, what I need to fix, and then the bottom. So I'm sure you guys are smart enough to implement this into whatever feedback you want to give. You don't have to do it for every single thing, but when you have something really serious and you bring up with a new grad, please sandwich it with a compliment or encouragement or positive feedback on both ends. All right. Utilize Socratic questioning. So Socratic questioning comes from Socrates himself. It's the idea that you're utilizing questions to promote the learner's ability to analyze and think through problems rather than just say the right answer is B, just like one single textbook right answer. It's like helping them kind of walk through how they got to the answer. It kind of flips the roles. So rather than the idea of like the sage on the stage just saying all the information and everyone just has to listen and accept it, instead, sometimes the teacher even like plays dumb, act as if like they're ignorant about the subject. Obviously you're not, and then that allows the student to not remain passive, but to actively help like push the dialogue forward. It also allows the students to develop self-efficacy. So rather than being dependent on you to be the giver of the knowledge, they realize through 3 different questions, like, oh, I actually did know the answers to this. I was able to come to the solution myself. It's the best way to promote self-efficacy rather than just like talking about what they need to do or change.
Hey guys, I'll get back to the episode in just a second, but I wanted to pause to let you know that if you love my podcast but wish there were more of these awesome episodes, well, I have great news for you. There is more. My Rapid Response Academy is basically podcast 2.0, plus the huge added bonus of community. I love hosting this podcast, but it's just me, recording into a microphone often by myself. And this extroverted gal who loves to both teach and mentor nurses just wanted more. So in the community I created, I get to teach live every Friday and break down topics that I think every nurse needs to know. From deep dives into the pathophys of every emergency you can think of, to some of the heart of nursing topics as well, like how to advocate with confidence for your patient, how to de-escalate situations, how to deal with bullies on the unit, how to be an amazing preceptor and charge nurse, and some of the mindsets and boundaries that have helped me stay in nursing for the last 20 years, not burn out, and thrive at the bedside. I love the opportunity to answer your questions live, and it's such a joy to see nurses supporting each other in this community. So, if you're an acute care nurse that wants to expedite your growth as a nurse and invest in yourself so that you can provide the best care to your patients, you would love my Rapid Response Academy. So to learn more, I put a link in the show notes for you. Hope to see you there.
All right. Here are some examples. Are there other ways of approaching this problem? So you just spelled out how we can fix it by doing these 4 steps. Is there another way we could do it? And let them kind of think through like, oh, actually we did this way, had the same outcome, whatever. Just the gears going. The other good one is making up fake scenarios. So what if this happened when you did that? How would you respond? Like we're expecting for the blood pressure to go up, but what if when we did this, the blood pressure went down? What would we do about it? So like making up potential scenarios, potential outcomes for this intervention that we're doing. With almost everything we do for patients, there's probably some sort of negative consequence. So we're doing this for the patient, but what could be the negative consequence of doing this? As we're titrating the vasopressors, what might be some negative outcomes? As we are, example off the top of my head, we're doing the dressing change this many times a day. Is there any negative consequences of doing such frequent dressing changes? Or whatever it is, like making them kind of think through all the rationale behind things. I do this a lot whenever we call for an order and the doctor says no. So I say like, why do you think the doctor might have not wanted to do this intervention? Like what might their rationale be? Just today, we had a patient who was retaining urine and the nurse called the doctor to ask for a Foley catheter. And the doctor's like, no, you can do straight cath in and out. And she was just so like, this is not right. The patient has to go through all these in and out catheters. We just put a catheter and leave it in there. And so I just asked the nurse, like, are there any negative consequences to leaving a catheter in for this patient that you can think of? Like, why do you think the doctor would not have wanted to do it in indwelling Foley? She's like, I don't know. I think it's the way to go. It's inhumane to keep having a catheter. I was like, well, she's a chemo patient who's on neutropenic precautions and she's a really poor immune system. Do you think maybe he's worried about her getting an infection because she can't fight the typical infection that me or you might deal with? And in and outs actually have reduced risk for CAUTIs. And she's like, I can see that. All right. What concerns do you have about doing blah, blah, blah? When they explain something to you, reflect it back and say, are you saying that blah, blah, blah? Or even reflect it back incorrectly so that they have to teach you the right way. What are the other questions we should be asking? This is especially important when you're doing your first admission, like you're meeting the patient for the first time. You let them go through all of the questions they would ask. And then we come to the hallway and say, are there any other questions we should be asking to rule out blah, 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 or to make sure that this is not going on, or to prepare for the worst case scenario, or is there any other question we should be asking? Is there anything else we would need to know before we begin this? So like before you do a procedure, before you do an intervention anytime, anything else we should know before we start? And then here's a really good question. How would we handle this if we didn't have a blah, blah, blah? Whatever the thing is that helps make things better. If we didn't have this person, if we didn't have this tool, if we didn't have whatever the thing is, how would we do it if we didn't have this? Because sometimes you don't have the saying. How would you be creative and think around it? So Socratic questioning helps them critically think and not just say the right answer, and that's it.
This next section is on setting goals together, and I can't stress this one enough. I feel like a lot of preceptors just think, well, if my orientee follows me around enough, eventually they'll figure out what they're supposed to do. But that's so far from the truth. It's super important to take time to set goals and then to take time to reflect on if those goals were met and to make a plan for moving forward. Because if we're setting goals and then letting them know they're meeting goals, they feel like they're actually acquiring the knowledge and the skills to do the job independently. And that is our goal overall as a preceptor.
So there's lots of kinds of goals. I would usually just let them choose the goals they want, but have some in your mind. And if they don't come up with that goal, then you're going to share it with them. So goals can be clinical skills, interpersonal skills, areas you want them to increase their independence. So here's some examples. This shift, we got to get you we have to start an IB. We're going to find a patient that needs an IB. This is our goal for today. You're going to get an IB started. You haven't done a Foley on a real human. We're going to find somebody that needs a Foley. It's happening today, right? Oh, you haven't primed an art line yet? Okay. Today, either our patient's going to need an art line or we're going to find someone else that needs one. We're going to give you a chance to prime the art line. All right. We're going to set up for intubation. Next time there's a trauma coming in, me and you're going to go set up for the intubation, be ready to go. We're going to administer medications through a feeding tube today. Whether it's our patient or someone else's, we're going to get a chance to figure out how to do that tactile skill of pushing these things to the D tube. We're changing a central line. We're going to change the chest tube drainage system. We're going to set up picture, but whatever the clinical skill is, this is the goal that we have that we want to make sure we accomplish this week or today, whatever it is. All right. Interpersonal skills we don't think about, but these are also skills we want to develop self-efficacy in for our person we're precepting. So today we're going to delegate something to the CNA. I want to see how you can do that delegation in a way that's collaborative, that's not condescending, that shows gratitude. You're going to delegate. Today, we're going to call the doctor and clarify orders. Today, we're going to update the family or the patient status. You're going to be the one to do it, and I'll just be there watching. But that's the thing I want you to be able to articulate is explaining the plan of care. Today, you're going to be providing discharge teaching. Today, you're going to call a report to whoever needs the report. All right. And then the final one is increasing independence. So today, I want you to be the one to pass all the medications without my assistance. I'll be here, obviously, but I want you to actually not have me like tinkering. You're going to do it yourself. You're going to complete all the patient assessments and be the one to document them. Today, we're going to move you up to you're managing 2 patients out of our 4 patients. Today, for this insulin drip, I'm going to let you take over titrating it. I'll be there to answer questions, but I want you to be the one that's following the protocol and titrating on your own. All right. I think it's important to debrief and pre-brief every shift. So I'm not talking about like a whole thing like you did in post-conference in nursing school. This is just like twice a day, you're going to sit down with them and prepare for the day and then wrap up the day. So great times for a pre-brief. Either before getting a report, you get together and be like, here's the goals that I had for you. Let's focus on getting this done today. Do you have any questions? Any goals that you have? Okay, let's go get a report. Or, so you get there late, after you receive a report, maybe you can brief me like, okay, so here's our goals for today. Here's our patients. Who do you need us to stick as one? What's our first priority? What do we want to make sure we get done today with this patient? Like kind of just preparing for the day, right? Just like military operations will like have a pre-brief to prepare for whatever the things they're going to accomplish today. We can do the same in nursing. And then another good time for a debrief after the shift is over. So before we give report to oncoming shift, let's get together, get your notes together. Are you ready to give report? Do you have any questions? What do we need to make sure that we have clarification on before we pass this patient on to the next shift? or even after you give a report, before you head home, just be like, hey, before you clock out real quick, this went really well today. I'm proud of you for doing this. Tomorrow when you come back, we're going to focus on getting a chance to do this thing. Any questions? And then something positive, just always like starting and ending the day, getting on the same page. Because what I've seen happen a lot is the new grad, you ask them, how you doing? And they're like, I'm doing great. Everything's going really good. Yeah, I love it. And you ask the preceptor, like, oh my God, they are struggling with everything. Like they can't do anything right. Like that's a very different perspective on how things are going because they haven't actually talked together about how things are actually going. Or on the flip side, you ask the new grad or the orientee, how's it going? They're like, oh my gosh, it's terrible. I just can't keep up. I feel like I'm just drowning all the time. It's so bad. And then you ask the preceptor, like, oh my gosh, they are killing it. They're like catching everything so quickly. But in the mind of the new grad, they don't realize they're doing so good because no one's given them that feedback or like kept them up to date on the state of the union, right? So this is so important to daily check in and make sure that you're on the same page as to how things are actually going. So when I was the ER educator, I made these little laminated front and backside pre-shift, post-shift debrief. So the preceptor didn't have to use them, but if they wanted to, they could fill it out each day with like a Sharpie just to keep track of it for themselves. And then for the end of the day, they would fill out the post-shift debrief. So they would have like a guide for talking through after, whenever they're debriefing after the shift. And then every day they would just erase it and start again. So the pre-shift huddle would be, great job yesterday, our last shift, doing the blah, 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 whatever the positive quality was. You did this with the doctor. I saw you master this skill. You improved your speed in this area. We critical think through this situation. You were such a good patient advocate with that patient in room 5. Like, start with the positive. All right, so here's our goals for today. When we talked about this, we're going to make sure that today you get a chance to call the doctor. Today, you're going to get a chance to pass all the morning meds independently. And then today, we're also going to, so just lay out the goals from the beginning. So then they know what they're working towards. And then after the shift is over, today, I observed you doing this, this, and this well today. Like, great job with that. Here's some things that I want us to work on as we continue in orientation. List them all out. And then I'm excited to keep investing in you because you bring so much, whatever, to the team. Joy, excitement, vitality, commitment, advocacy, whatever like positive attribute that you want to squeeze in there, something positive in the end. Okay, this one is so important and it seems minor, but taking time to build them up in front of their peers will help other people learn to trust them as well. If everyone's like, who's a new girl? Like, who's a new guy? I don't know. But the more that you are instilling that they are improving, they are growing, they are doing better, they will feel more confident and the team will treat them as if they can handle it more. So you are going to help them launch, help them be successful by what you're saying out loud. So not just what you say to them as a person, but what you say to the team. So just some examples. Did you guys see Jason rocking that aerator in the code today? He was like right on it, good technique, squeezing the bag appropriately. Like, you think he did this for years. He did a great job. Or, guys, Chris is already managing half the team independently. Like, he's doing so great. With Chris able to hear that, right? I'll always say things like, dude, the patients love Jen, like maybe even more than me. She was born for this. The patients are loving her so much. That's great feedback from them. Whatever to just like bring them in to be a part of the team, to be a part of like the camaraderie, the culture, instilling that they are positive. Not talking about like, oh my gosh, they did this wrong and then I had to correct them for this. And you should have seen whenever they did this thing, I had to tell them, like that is not a good preceptor. Maybe you did have to do those things, but you don't need to talk about that to everybody else, right? You're going to be building them up in front of their peers. That's a good preceptor. Okay, so we've talked about all these ideal circumstances, like things that you would do to just help this new grad who's invested in learning to be successful. Like, that's all the good things. But what about the special circumstances? What about when you have the overly cocky one, the it's everybody else's fault one, the just not motivated to do anything one, the I just can't do it one, and the rotten apple who's just like negative Nancy and nothing can be positive? How do you handle those people? Because all of these beautiful techniques have to be adjusted a little bit when you have someone like that. Okay, so the overly cocky one. How do you handle when you're precepting someone and they just think they already know everything? They're overly cocky, like they don't need what you have to say, or at least they act like they don't. Maybe they do, but they act like they don't. How do you handle someone who's just overly cocky and doesn't seem very teachable?
So, man, the Rapid Response Academy members had some experiences with the overly cocky new hires, so they had to orient. This definitely poses a challenge, but let me give you a different perspective on maybe why the person is acting cocky and how we can work to overcome that obstacle and move them towards independence safely without them thinking that they actually do know everything.
So I was always the person that if we had that new grad that no one could manage, they're like, oh, well, we'll give him to Sarah to precept. Like, darn it. No, I want the excited, sweet new grads that want to learn everything. Don't give me the cocky know-it-alls. But I am very good at just being direct and holding my ground and not being like intimidated by them.
So I shared a couple examples of nurses that I've precepted that it wasn't just a defense mechanism. They actually generally thought they knew more than everyone else, and they clearly did not. One nurse, we put her with the paramedic in the ER to, improve her IV starting skills. This paramedic was like the best at starting IVs in the entire department. And he went to give her a tip on how to maybe angle the catheter differently and maybe hold her hand a little bit differently to see the flash. And she takes her badge, points at him and says, "This says RN. I'm the nurse. You're the paramedic. I think I know how to start an IV." So that for me was like very obvious. This person is not very teachable, when to me, the best person in the department to teach you, you got an opportunity to learn from them and you just squashed that opportunity and showed your true colors. Another time when I was precepting in the CVICU, I had a nurse who was very fond of himself, but did not understand vasopressors, but acted like he knew them so well. But when I would ask him questions about what this medication does and how it's going to affect the vital signs, he honestly did not know the answers. And so I encouraged him, hey, tonight when you go home, I think you should take time and just study these 3 vasopressors. So when we come back tomorrow, you could be more equipped to manage this patient's high acuity, these really high-risk drugs. And he just didn't do it. And the next day was just kind of like willy-nilly titrating stuff, not really thinking through, but acting like he knew what he was doing when clearly he did not. In both of those circumstances, I talked to the nurse in person and shared my concerns. And honestly, if they had been teachable and apologetic or humbly wanting to learn, it probably would have never gone any further. But because they acted like what they had done was totally fine, totally acceptable, nothing needed to be corrected, I ended up bringing it to leadership. And both those individuals, we did not let them even finish their orientation because they really weren't fit for the level of care we wanted to provide to the patients that were entrusted to our care. And that's hard stuff, but I feel like it's our ethical and moral responsibility to be, what I'll talk about in a minute, as the guardians of the profession.
Okay, and then the rotten apple one, I have straight up told people, you have brought a very negative culture to this team. Everything is negative that you talk about. You have nothing positive to bring to the conversation. Is that something that you're hoping to accomplish, or is this just an accident? Is there a way you can shift this in yourself before we move forward? Because this is going to be a problem with the culture we've established in this unit. I know not everyone's as forward about those things, but like one bad apple spoils a whole bunch, and I don't have time for it. When I was a nursing professor, I worked with other professors. She had the office across the hall from me, and she used to always say, we are the guardians of the profession. So if we just let everyone through, if we just pass everyone on orientation, if we just let everyone pass nursing school, what does that do to our profession as a whole? We are tainting it if we allow people who are not teachable, who are, bad attitudes, who it's everyone else's fault. If we allow all those people to infiltrate our profession, we are making it worse for everyone and for patients. So it's guardians of the profession. As the preceptor, I would say it's your ethical and moral responsibility not to just be like, I guess she did good enough to come off orientation. No, to guard the profession and say, nope, they need to work on this thing. This still needs to be accomplished. Their attitude is this. And there's things that you, not being the leader, cannot fix. Sometimes you'll just have to escalate it to leadership and let them know, this is what I'm finding. This is the challenge I'm having. Not just meekly continue to deal with it, but actually address it head on.
Someone brought up the additional challenge of precepting someone who's actually senior to you, either in nursing experience or just in age. Say you're a 25-year-old nurse who's precepting a 45-year-old new grad, or say you are maybe a younger nurse who's training someone who's been a nurse for many years or just into your hospital. That can be a very awkward situation to be in. And I think my advice is just to call it for what it is. I would just say, hey, there's probably some things that you can teach me right now. So feel free to. I am still open to learning. I'm happy to show you about my hospital and how we do things here. But if there's things that you feel like I should learn, I would love to. I'm always open to learning and growing. So yes, it can be a challenge, but I think if you're humble about it, it kind of mitigates any awkwardness that might be there. We went on a little bit more talking about specific examples that some of the Rapid Response Academy members have experienced before. They had some great questions, but I don't want to share their questions or experiences without their permission on the podcast. So to wrap it up, some of the ways that I have found beneficial to help promote self-efficacy in the person that you're training is first, establish expectations from the beginning. Make sure they know how you like to teach, hear from them, how they like to learn, and try to merge the two. Remember the whole concept of paying the confidence bank. So make sure you're depositing enough positive affirmation, encouragement, building them up more than you're withdrawing from that confidence bank. Remembering the masterful art of the sandwich method and using tact when doing that, not doing it for every situation. It can get a little cheesy, but for the really hard conversations, those crucial conversations, making sure to sandwich it with a compliment. Using Socratic questioning whenever you can. So rather than just vomiting information on them, asking questions to draw that out so they can learn that they actually do know the answers to stuff. Taking time to set goals, both clinical goals and also social goals, and just independence goals, how they're becoming more and more independent from you. The whole pre-brief and debrief at every shift is so valuable. So you guys are on the same page the whole time. And then remembering to build that person up in front of their peers, not just to their face, but also in front of other people so they can acclimate to the culture of your unit and feel like they're really a part of it. Remember that your primary role as the preceptor really is more of a mentor than the person that has all the answers. Your biggest goal really is just to prepare the nurse that you're teaching to critically think, to stay organized, and to be able to advocate for their patients without you being there. So, for those of you that are new to precepting, I hope this 30-ish minutes was helpful to you. I wish you all the best. It really is a privilege to precept. I feel like once I started precepting, that's when my nursing knowledge really launched, because the person that I was precepting asked me so many good questions that forced me to make sure I really knew my stuff. So may you enjoy this opportunity, both to give that to the profession, but also to develop yourself professionally through the process. Happy precepting, guys.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.